Thanks for inviting me to talk on this very interesting topic, and I'm looking forward to hearing your questions at the end. Please just note I'm an economist. I have not got any medical training. I don't have any relevant financial relationships, and I will be drawing on a paper with my co-authors Joe Lipscomb, Albert Kuo, and Christian Tomasetti, which has been submitted to Cancer. In my short presentation, I would like to give you a little primer on health economics, or a refresher if you've done it before, and talk about the cost effectiveness of the existing cancer screening in the US and how that might compare to the cost effectiveness of a multi-cancer blood test. And I have one slide at the end where I will speculate about the policy implications. So my short refresher on health economics. Needs are many, but resources are few. There are many interventions in health that we cannot necessarily afford to use to intervene with all of them. So we need to pick the highest priorities. So one way to do that might be to think about the cost per death averted. You know, that makes somewhat intuitive sense. On the other hand, we might want to modify that and think about lives saved in very elderly people having a different value from those saved in babies, because the number of life years that are gained differs, so cost per life year saved. But there again, some interventions may substantially improve the quality of life without necessarily changing life expectancy, and that's where these QALYs come in, quality adjusted life years. And it's a metric that's often used to set health priorities. So if we can calculate the cost per QALY, what's good value? So the answer is it depends on the country. Rich countries can afford a higher number of interventions with more cost per QALY, whereas very poor countries can only afford a limited basket of interventions with a lower cost per QALY. And the threshold that's been recommended is using something like 1 times per capita income of the country. So for the US, the threshold that's commonly used is 50,000 US. Any health intervention costing less than $50,000 per QALY is considered good value. And that particular number was chosen for no other very good reason than in 1950, it was the highest cost intervention that Medicaid would pay for, which was kidney dialysis at that time. And a similar metric is used for the UK, £30,000 per QALY. And for poor countries, obviously the figures used are a lot lower because the country income level is lower. So, cost effectiveness methods have been used when generating choices about cancer screening. So obviously we only would use interventions that are effective, but then there are various additional choices. When doing cancer screening, we need to decide which groups should be screened, who is at the highest risk and therefore most important to screen. What ages should we use for the screening? How frequently should we screen? And cost effectiveness can help us make those kinds of decisions to fine-tune our cancer screening programs. So here are existing programs, and in a second I will show you information about the costs and cost effectiveness of these different screening programs, and then we can compare that to this potential multi-cancer blood test that might be available in future. So here I've calculated what I call the annualized cost of a screening program, because that's going to be important for governments when they budget for these programs. And how I got this is to calculate the cost of the screen itself divided by the interval over which you're screened. So breast cancer mammograms cost a couple of $100, and people are screened every 2 years, so the annualized cost is $100. And let's compare that to colorectal, where if you do a colonoscopy The recommended interval is every 10 years. And so therefore the intervention screening costs a couple of $1,000, which turns out to be $200 a year on an annualized basis. Okay, and I do that calculation because there are different screening intervals. And obviously we don't yet know what the multi-cancer blood test will cost, but the expectation is it might cost a couple of $100 for the blood test. Then there's imaging that's required in a certain proportion, and this would occur once every 2 years. So you can see the actual cost is in the ballpark of our existing screening programs. So how about the cost effectiveness of these different screening programs? So just because something is inexpensive doesn't mean that we should buy it. And likewise, some things are quite expensive, but they're very good value and we should choose them. So you can see here, kind of paradoxically, cervical cancer screening is the cheapest annualized cost, but it's not as cost effective as breast and colorectal cancer, perhaps because cervical cancer is much less common than either breast or colorectal. But you can see using the threshold value of 50,000 that 3 of these are very cost effective. Their cost per QALY gained is a long way below the threshold. And lung cancer, as long as it's done in very high risk individuals at certain ages, is more or less meets the threshold for cost effectiveness. Okay, so there are a lot of factors that go into affecting how cost effective screening is. Okay, so I'll just go briefly through a few of them. So if screening is more costly, as we saw in the previous slide with lung cancer, that makes it often less cost effective. The cost per QALY increases. If the screening test is less specific, i.e. it generates a lot of false positives that require additional testing to screen out, that makes these tests less cost effective. And similarly, if the screening test is less sensitive and is less likely to pick up actual cancer cases, again, that makes it less cost effective. To make it more cost effective, we can try screening only the higher risk population groups. So you can see all of the US guidelines were for populations of at least 50 and older, where incidence of cancer is higher. And if treatment costs are higher, that also makes screening more cost effective because we avert late stage cancer treatments that are very expensive and instead substitute lower cost screening. And finally, the younger the at-risk population is, the more cost-effective screening is because it saves more life years. If you can catch breast cancer in a woman age 50, you're saving more life years than if you catch it in a woman who's 85, let's say. Okay, this slide has a lot of information, so please be patient. On the left side, I have listed the incidence of the top cancers by numbers for the US from the GlobalCan data for 2020. And you can see the cancers that we screen for, breast, lung, colon, are right up there as having the highest incidence. But if we move to the second column, the order changes because we've been more successful at catching and treating early some of the cancers. So you can see breast cancer is no longer the highest priority in terms of deaths because we successfully screen and treat. But on the other hand, you can see cancers entering that second column that we didn't see in the first column, cancers that only occupy a smaller proportion of new cases, but a large proportion of deaths. So you can see pancreas, liver, the upper GI, esophagus, and stomach in that list. So these are cancers that cause a high proportion of deaths, and that may make them higher priorities to try and find a screening test. That's not the only factor, but that might be one. So in the third column, what I did was to calculate the ratio of the proportion of deaths from a cancer by the proportion of incidence. And these are the 5 cancers where the deaths are twice as important as the incidence. And you might think these are high priorities for a new screening test. Okay, it's not the only factor, because likewise also the overall prevalence might matter, but these are 5 key cancers that we'll see in the slides following. Okay, so the multi-cancer blood test offers the opportunity to capture cancers that we don't capture by current screening. And so the question is, how well does this work? So I've put on this slide some information from this DETECT-A trial, which shows you that in a group of 10,000 women examined over and followed up over a year, there were about 100 cancers detected, of which a quarter were detected by regular screening, about half were detected by symptoms, but another quarter could be detected by the multi-cancer blood test screening modality. And it had some advantages in that it was able to detect relatively early stage cancers that could be treated with curative intent, and also the amount of false positives that involved invasive kinds of follow-up, surgery or bronchoscopy, was very few, only 3 cases. The less good news is that the sensitivity of the test was acceptable, but obviously would be desirable if it could be higher. Okay, and this slide from Ahlquist shows you that once the cancer has been detected by the blood test and a follow-up screening, that it was reasonably good at detecting the site of the cancer. Okay, and it varies according to the cancer how good that fit was, but this is a good signal in that it suggests that people who are detected as having cancer on the blood test, there's a good chance that one can identify the site of it without doing a huge amount of invasive follow-up. Okay, so going back to the priority cancers that I mentioned, there are blood tests being developed as single cancer blood tests currently. So for example, uterine cancer and ovarian cancer and gastric cancer. The disadvantage of the single cancer blood tests is that since several of these cancers are fairly rare, it's not very cost effective to screen single cancers one by one. Okay, uterine cancer may be cost effective, but the ovarian cancer would not be unless you pick a very, very high risk population. And the problem with doing that is that you then miss cancers in the lower risk population. I believe that's one of the issues with lung cancer. You can focus on the highest risk population who had the highest smoking history, and it becomes more or less cost effective to do the screening, but you still miss a lot of people whose cancer came about, perhaps because of secondhand smoke or other factors. So the advantage of the multi-cancer blood test is, what if you could do a single blood test, and instead of doing 10 different blood tests for 10 different cancers, do one single blood draw and then spread out the costs over detecting more cancers, and thereby enabling you to screen for these more rare cancers. So this is where we get to the paper that Joe Lipscomb and Christian Tomasetti and Albert Kuo and I wrote. So obviously this new screening test is very new, and we don't have a lot of the parameters that we really need to do the full set of calculations. But it was desired to do an early cost effectiveness to know if we would be in the right ballpark and that this might be feasible. And also doing an early calculation allows us to be very precise about which parameters we need more information about, i.e. where are the priorities for doing further research to refine our calculations. So what we modeled here is as if there were 3 baskets of cancers with different characteristics, and we picked 2 for which there was no test currently, for which there are guidelines, and 1 for which there already are guidelines and it already exists as a test, but it doesn't manage to screen the whole population. So we had to make some assumptions, based on what data we can find about how sensitive these tests are, and it varies according to the cancer. In the 4th column, you can see the data on what the assumed survival gains are if it can be detected early, and it varies across these cancers. And based on that, we could get information as to what the cost effectiveness of these screening would be if we did single cancer blood tests. Okay, and what you can see here is that if uterine cancer were done as a single cancer blood test, it probably would meet the threshold for cost effectiveness, but for the other 2, it would not, unless you could pick a very, very high risk population and restrict the test to that. Okay, so what we then did is redid our calculations, not cancer by cancer, but testing all the population for all of these 3 baskets of cancer at once, and it redid the calculations. And the result is basically that the cost effectiveness of the combined test, the multi-cancer blood test, will be lower than the cost of any of the individual 3 cancers. And we can then actually compare it to the threshold as well. So in this case, the uterine cancer as a single test had the best cost effectiveness number, and the combined multi-cancer blood test had an even better performance. So I think that's on the next slide here. And it shows you that the cost effectiveness for the multi-cancer blood test, which can potentially get information on up to 8 different cancers, is definitely in the ballpark. Our estimates are around 25,000 per QALY, but that also allows for some sensitivity analysis that it might not be quite as good as we predict, if some of the parameters were different. And it's certainly very comparable to the current threshold, the current cost effectiveness of existing lung cancer screening. So this was our encouraging results for moving forward with further development of a multi-cancer blood test. Okay, there are a lot of limitations of our findings. It was a very complex thing to do, even when we limit this to 3 cancers, and ultimately, there may be 8 to 10 cancers which are involved. There are some cancers like pancreatic and ovarian about which we may know less because we currently can't detect them very early. And also treatment regimes may not be very well developed as yet. There are also concerns about existing screening. If you ask people to come and be screened with a blood draw, is that going to interfere with their compliance with breast cancer screening or with colon cancer screening? That would be bad if people don't come for these other screenings, because we know that blood testing is less good for both breast and colon cancer because we have more direct ways of testing for those. We know that colonoscopy can detect precancers, as can breast cancer screening, whereas blood testing is less likely to detect precancer. The other possibility is that there are people in the population who don't like invasive tests like mammography or colonoscopy, but who might be more willing to come and be tested if all that's required is a blood draw initially. And I don't know how the figures are for the US, but in Ontario, up to a third of the at-risk population are not up to date with their screening. In the future, we plan to extend this model not simply to a one-time only screen at age 50, but to model what happens if you test the population, let's say between 50 and 70 every 2 years. And also, we didn't separate by sex. Uterine cancer, which is the relatively cost-effective cancer, isn't important in men, and therefore the estimates probably have to be disaggregated for men and women. And also, a new screening test may impact cost effectiveness of the existing test because you're duplicating some of the screening. Anyway, just to conclude, these are my opinions. My view is it's unlikely that the multi-cancer blood test would displace screening for breast and colon cancers for the reason I mentioned about not being able to detect precancers. I think the multi-cancer blood test is also unlikely to be important as yet in low and lower middle income countries because they do not have facilities for treating cancers once they're identified. And also they don't have access that's broad enough for the imaging that's required for the confirmatory testing. And I think there's going to be more research needed and more treatment options developed if the multi-cancer blood test allows us to detect early stage cancers for some of the existing cancers where the death rates are unusually high relative to the prevalence.